Hello, and welcome to another segment of Let's Get It Straight. My name is Katherine West. I'm an infection control consultant, and I work primarily with fire and EMS groups. Our subject today is to help clarify differences between medical facilities, policies, and procedures and those for EMS, especially with regard to published guidelines from the CDC. So let's go ahead and get started. First, let's review our objectives for this session. To clarify the differences between the medical facility and EMS practices, clarify vehicle protections awarded you for airborne and droplet diseases, post-exposure, what's the same, and what is different and why. The first thing we want to do is clarify some terminology. Evidence-based practice versus what we're hearing more and more in the world of fire EMS, which is more the KISS principle. Keep it simple, stupid. So what does evidence-based practice mean? It's a system that uses the best available evidence, clinical expertise, and patient values to guide our healthcare decisions. The goal is to improve patient outcomes and quality of care by incorporating the best research into our clinical practice. You may also hear the term empiric, and empiric has served us well for many, many years. And I'll give you an example in just a moment. But empiric relies on medicine and other branches of science, on observation and experiment, and is based on experience. So that brings us to one of the real big topics and confusing ones right now, and that is masks versus respirators. Right up front, we can say there is no science to show respirators are more protective for these diseases, and that we are to follow the EMS guidelines and not the hospital guidelines. So let's look at some of the data on respirators that have been published. Going back to March of 2015, from the National Institute of Occupational Safety and Health came this statement. And the bottom line here is the bottom line. There is no requirement for EMS personnel to wear an N95 respirator while transporting a TB patient. 2015. Perhaps this study that was published in the Cleveland Clinic Journal of Medicine sums things up best by looking at all published data on the subject of surgical versus N95 masks. The article is titled, "What Mask Should I Wear to Protect Against Transmissible Acute Respiratory Infections?" The study points out that clinical trials have not shown any direct advantage to using an N95 respirator compared with a surgical mask for many acute respiratory infections. Goes on to say, and this is really important in understanding the published data, N95s have been found to be better than surgical masks in laboratory studies, but this was not translated into a clinical advantage. Clinical trials conclude that evidence remains insufficient to determine whether N95 respirators are superior to surgical masks in protecting healthcare personnel against transmissible acute respiratory infections in the clinical setting. So these topics are all reflecting published data. Now, empiric. Surgical masks have served us well for centuries. Yes, for centuries. So, the Healthcare Infection Control Practices Advisory Committee, HICAC, which makes recommendations to the CDC. They do research, they pull data together, and they make recommendations to CDC. And they were looking at surgical masks versus N95s. In collecting data, analyzing it as a group. This is an independent body. And the recommendations came forward and were to be voted on in November of 2024. However, those votes have never taken place, and this group is now no longer in existence. But here's how it worked. In this example, they look at laboratory confirmed viral respiratory infections and looked at 13 studies that were published and graded them on strength, precision, consistency, directness, and confidence. This is important to know, how the process is conducted, that it's not just a few people making these decisions based on nothing. They're based on data. So the summary suggests that there's no difference between N95s and surgical masks. And the discussion continued. And here, an additional 10 studies and then an additional 4 studies were evaluated. And the upper one, pandemic laboratory confirmation of viral respiratory infections. Again, the data suggests no difference between N95s and surgical masks. The second one, seasonal laboratory confirmed viral respiratory infections, and again, suggests no difference between N95s and surgical masks. So we'll look at the COVID-19 guidelines that were published for EMS and are still in effect. So what do they say for EMS versus a medical facility? Because what we're seeing happen oftentimes is that what's being put out are guidelines for the medical facility and not the guidelines for EMS. So for COVID-19, it says, close the door and window between the compartments before we load the patient. During transport, we want to have good ventilation in the compartments, and so the HVAC should be placed on the non-recirculating mode. This maximizes air exchanges to reduce infectious particles in the vehicle. The other protection that you have is your rear exhaust fan. It is used to draw air away from the cab toward the patient area and out the back of the vehicle. If possible, you were not to do aerosol generating procedures, and bag mask devices were to be fitted with HEPA filtration to filter expired air. So these were the EMS-specific guidelines. But early on, in fact, January of 2020, at the real onset of COVID-19, the World Health Organization put forward their approach, and they were spot on. It said, we want early recognition and source control, meaning we will put a surgical mask on the patient. If they can't tolerate it, let's use an oxygen mask. We're going to apply standard precautions, good hand washing. And then we also want to implement droplet and contact precautions. That's use of a surgical mask, droplet precautions. Now, they went on to say, when applicable, airborne precautions would be used for aerosol generating procedures. And they specifically listed those procedures. Taking sampling from the lower or upper respiratory tract. EMS does not do that. Collection of serum specimens. EMS does not do that. Open suctioning. EMS does not perform open suctioning. You don't do bronchoscopy, you do intubation, and yes, you do CPR. So the EMS guidelines published by the CDC in July of 2020 said respirators were to be used for aerosol generating procedures, and those listed for EMS, intubation, CPR. And then the question was coming up, well, what about aerosol medication administration? So NIOSH put out a study touting the importance of your rear exhaust fan, and that we would want to put it for COVID-19 on the high setting, along with putting the heating and air conditioning on the non-recirculating cycle. Again, specific to EMS. Now, your rear exhaust fan. The rear exhaust fan takes the air from the patient compartment and vents it directly out the back of the vehicle. This helps ventilate the ambulance and remove potentially infectious particles. And that can be set so even the air exchange happens a minimum of every 2 minutes. Air in the back of your vehicle is completely exhausted out, new air comes in. You'll see the reference at the bottom. One of them is the ground vehicle standard for ambulances. The latest version was July of 2022. So what about suctioning? As I said, you don't perform open suctioning. You maintain a closed, filtered system. See the blue top in the photo? Some are red, some are white. That is where the filter is. And you don't break your system. It's maintained as a closed system. And it's vented directly to the exterior of the vehicle. Again, ground vehicle standard for ambulances, and the section number is there for you. Now, your portable suction also has either a blue or red or a white top which contains the filter. So what is open suctioning? What am I talking about that you don't perform that? It's a technique that involves a sterile, one-time use of a catheter and requires disconnecting a patient from an oxygen source, such as a ventilator. They open also the tubing in cases to take samples or instill medications. And you don't perform that. So what about aerosolized medications? And I found this statement from CDC that I thought would be helpful. It says aerosols generated by nebulizers are derived from the medication in the nebulizer. It is uncertain whether potential association between performing this procedure and increased risk of infection might be due to aerosols generated by the procedure or due to increased contact between the care provider and the medication being administered. They say limited studies are available on this. Now, I did find another study that was published by the Journal of Aerosol Medicine and Pulmonary Drug Delivery, and this came out in 2020. The title, Reducing Aerosol-Related Risk of Transmission in the Era of COVID-19, an interim guidance endorsed by the International Society of Aerosols in Medicine. Seems like that's pretty to the point. And they state, medical aerosols produced by inhalers and nebulizers, such as those containing bronchodilators, anti-inflammatory agents, mucokinetics, antivirals, and antibiotics, do not contain pathogens unless the nebulizers are contaminated by the patient or the health care provider. Pretty good synopsis there. So we're talking about difference between medical facility guidelines and EMS transport. So here's my comparison to kind of make the point. In a medical facility, staff has multi-hour contact time with a patient, 8-hour to 12, 14-hour shifts or more. EMS generally has short patient contact times. Medical facilities cannot control the airflow in a given patient care room. In EMS, you have the rear exhaust fan, and you can put the heating and air conditioning on the non-recirculating cycle. As we just discussed, medical facility staff perform open suctioning, and EMS maintains a closed filtered system. So I hope this helps make the point here, and that we need to really look at the guidelines and follow those for EMS. And there are always EMS-specific guidelines that get published. Now, here's another one that's kind of timely that we can add some difference to, and that's exposure to measles. We know that measles can hang in the air for up to 2 hours after a patient or person has left an area. So if you're not wearing a mask for respiratory protection, then you could have an exposure. Medical facilities need to air out their patient room for 2 hours after the patient has left the room. And they're out instructing EMS that you need to open and air out your vehicles for 2 hours after transport of a patient diagnosed with measles. But does EMS need to air out the back of your vehicle for 2 hours? Most likely not if you have been using your rear exhaust fan and putting your HVAC on the non-recirculating cycle. Nothing hangs around in the back of your vehicles. It is vented directly out of the vehicle, and that is very different from a hospital room. Now let's switch over to tuberculosis. Here again, there are specific guidelines for EMS. You were listed in the December 2005 TB guidelines as a non-traditional facility-based setting. And the pages that say EMS that apply to you are page 25, page 126, and page 134. And NFPA 1581, and you have the section number, says follow the CDC guidelines on how to conduct a risk assessment. With regard to transport of a suspect patient, EMS guidelines say, put your ventilation system on the non-recirculating cycle, turn on your rear exhaust fan if it's not automatic, put a surgical mask on the patient, that is source control, and that the risk for EMS for contracting TB is low. What about patient transport for in-hospital? And here it is. It says a patient on airborne precaution, known or suspected to be infected with TB, measles, or chickenpox, healthcare personnel transporting them, and they're on airborne precautions, do not need to wear a mask or a respirator during transport if the patient is wearing a mask. In the case of chickenpox, for example, to make sure that skin lesions are covered. So some things a little similar and some things remain different. So what about Ebola? And we got from CDC and OSHA that if Ebola virus contamination is known or suspected, care providers should wear a long-sleeved closed front gown, disposable nitrile or powder-free latex gloves, but we're not going to use latex, eye protection, and an N95, fit-tested respirator. This is medical facility personnel. So what are the Ebola guidelines for EMS? That we do standard precautions, gloves and good hand hygiene, droplet precautions, which is we put a surgical mask on the patient, and contact precautions. That deals with cleaning of our vehicles. We're to avoid contact with contaminated surfaces, and when within 3 feet of a patient, the 3 feet is empiric, okay, from history, and has served us well. For droplet, we have a 3-foot rule. Then we would put on a cover gown, gloves, face shield or eyewear, and a mask, and use good hand washing. Okay, one more difference to point out. In the OSHA regulation, it says, applied to medical facilities, no eating, drinking, or applying of cosmetics in the workplace. However, when you go to the compliance directive, that's the companion document to the regulation, you see that there is an exception for ambulances. Yes. And the exception is you can transport food in your vehicle, you can eat in your vehicle as long as you follow two rules. Rule number one, that if the area you're going to transport food or eat is covered with blood or OPIM, you will clean it first. Aha. Number two, if the clothing you're wearing is covered with blood or OPIM, you would change it first. Very different rules. And post-exposure testing. It was in 1999 that OSHA published in a compliance directive for the bloodborne pathogen regulation that an exposed employee did not need to be seen immediately and have baseline blood work drawn. That in accordance with the CDC, everything was to start with testing the source patient. So medical facilities seem to still be having the employee immediately seen following an exposure and drawing baseline tests. I'm not sure why. The key to knowing if there is any need for follow-up for an exposed employee is the results of the tests on the source patient. So, for fire EMS, it is very clear that all testing begins with the source patient. That's the medical facility's responsibility, and there is no need, nor can a medical facility require that EMS or fire personnel sign in to the ED and have baseline tests drawn. That may be the hospital's policy for their employees, but that is not the policy for fire EMS. So these are the guidelines that OSHA is enforcing using the general duty clause. They're enforcing the work restriction guidelines from CDC, all of the post-exposure guidelines, the vaccine and immunization guidelines, and the TB guidelines, including the update published in May of 2019. So once again, in summary, this is why EMS guidelines differ from those of the medical facility, especially with regard to airborne and droplet transmitted diseases. Your vehicle has and offers you built-in protection, your rear exhaust fan and your HVAC on the non-recirculating cycle. So that brings us to the end of this segment. I hope the information has been helpful in sorting out some of the confusion. We want to use evidence-based and empiric guidelines to our practice. That gives us best practice. And we don't want to just arbitrarily pick things. If your department wants to do that, that's fine. But that can sometimes bring about a false sense of risk. And we want to keep risk in proper perspective. If you have any questions or need additional information, please give me a call or send an email. Thanks again for listening, and I hope you'll join me again for another segment of Let's Get It Straight.